I will now welcome our last presenter for the day. So Lisa Nussey is with us, and Lisa is going to be presenting. She's a recent graduate of the master's program at McMaster in our health research methods program, and she's going to be presenting her thesis findings called Responsibility and Justice, Considerations for Increasing Access to Prenatal Care. So a little bit of background about Lisa before I hand things over to her. She's a registered midwife here in Hamilton. She recently completed her master's, as I said. She is the founder and co-coordinator of the Hamilton Midwifery Outreach Team, which is a group of volunteer midwives who provide low barrier prenatal care to people in the shelter system. She also works with the Hamilton Social Medicine Response Team, or HAMSMART, which is a grassroots interdisciplinary health organization that provides care, low barrier healthcare to people in Hamilton. And HAMSMART works in particular to promote the idea that health is political and that only through social transformation can the barriers to health and healthcare truly be addressed. Lisa's areas of interest are related to community-centered care and the social determinants of health and social medicine. Welcome, Lisa, and we've got your slides up and you are ready to go. I will interrupt you at the end probably to allow about 5 minutes for questions. And there's polls up on the screen, so if you can quickly do a little poll about the talks you've heard so far, that's helpful for us. And welcome, Lisa.
Good afternoon, everyone. Thank you so much. It's such a pleasure to be here. I just realized in listening to the bio I submitted, I gave away the punchline to this presentation, but I hope you'll stick with me for the next 20 minutes or so. I just want to begin by thanking the organizers from the McMaster Midwifery Research Center. It's a real thrill to be here, and I just had to scroll through the list of the participants, and I see some old and familiar names from far and wide, as well as midwives joining us internationally. I'm so excited to be sharing this work with you, and I look forward to the conversation in the question and answer period, which I hope I will get through quickly enough to give time for. Why doesn't it move? There we go. Okay, so I want to begin by acknowledging that this work was undertaken and completed on the territory of the Haudenosaunee Confederacy and the Anishinaabe Nations, protected by the Dish with One Spoon and Two-Row Wampum treaties. I strive continuously to learn the history of the stewards of this land, to teach it to my children, and to be responsible to it as a treaty person on Turtle Island. The TRC and the Missing and Murdered Indigenous Women and Girls report single out health and social services as disciplines that have been complicit in the injustices of the residential school and the national disgrace of missing and murdered Indigenous women and the genocide that they constitute. The calls to action of both reports describe for us a path to acknowledging and righting those wrongs, and I have tried to responsibly bring some of those calls to action into this work. This is what I hope to cover today, and as I said, I plan to leave time for questions and answers and comments and feedback, which I would be very grateful for. I want to talk a bit about the context and that this work grows out of a 10-year and ongoing effort to expand and enhance the Hamilton Midwifery Outreach Team, formerly the Shelter Health Network Midwifery Care Team, for some of you who might be more familiar with that name. As Beth described, a volunteer team of midwives and family doctor providing ad hoc on-call prenatal care to people accessing the shelter system and adjacent services. The experience of trying to fill the clinical gaps for this important group of people in the city of Hamilton, Ontario, led to the development of a mixed methods research program, of which this study is one part. The other two parts are a retrospective chart review on inadequate prenatal care, which was published in 2019, and an unpublished investigation into the experiences of patients who receive inadequate prenatal care. The goal of this whole program is to inform the development of novel models of care delivery that better meet the needs of those who struggle to access care. There's a paucity of research on care provider experiences and understanding of inadequate prenatal care, and none attending to the local context, which I think is important. And thanks for taking some time out of your presentation, Liz, to explain a bit about the context in Ontario, because that is the one I'm referring to in my presentation. The research question thus is, how do health and social service providers understand the problem of inadequate prenatal care in Hamilton? And this is the question that I used to build the ideas in this work. Sally Thorne's interpretive descriptive method was a natural choice for this work with its stated aim of resolving a disciplinary-based health service problem. And its explicit attention to interpretation allowed me to try to make sense and understand how people's experience enabled them to think about what is possible in terms of intervention, which again was very important to this work. And given my own ideological commitments, I've approached this work with a critical theory lens. The use of critical theory means paying explicit attention to questions of power. Critical theory posits that our ideas, drives, and understandings of the world are rooted in the structural and organizational features of society, whether or not we are conscious of it. And in fact, critical theory argues that we are often not. Per Freeman and Vasconcelos, quote, central to the critical theory argument is that systems like capitalism produce knowledge in such a way as to obscure their oppressive consequences. I want to take a quick second here to highlight a concept that figures quite centrally in the work, the social determinants of health. I use the internationally recognized definition of the SDO in my analysis, and the WHO defines SDO as the non-medical factors that influence health outcomes. They are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems that shape the conditions of daily life. These forces and systems include economic policies and systems, development agendas, social norms, social policies, and political systems. The emphasis here is mine, but I would say so too is it that of the World Health Organization. I used purposeful sampling of care and social service providers in the city who I knew were either doing the work of increasing access to care deliberately or happened to care for people by default who had no access to care by virtue of the fact that they were on call when people came in presenting with no prenatal care. So obstetric providers working in the labor wards, same as nurses, as well as pediatricians. And I collected the data myself by way of semi-structured interviews and a few focus groups. I used the regularly cited Braun and Clark technique of thematic analysis, and I added in Eakin and Gladstone's value-adding analysis, which offered important tips for being responsibly reflexive, reading the data for what is not there, and contextualizing meaning. Okay, now we're going to jump into it. Before I begin talking explicitly about my findings, I want to spend some time talking about just a minute. I don't have time to summarize all of them and the interpretations, or even regrettably, to share enough of the beautiful, insightful, and helpful quotes that this work is built around. I just want to take here a way too quick minute to provide a skeletal overview of where my research corroborates some of the more well-established ideas in the literature that I won't be able to cover in the body of the presentation. If I were to summarize this slide in a nutshell, the story of inadequate prenatal care, both in the literature and this study, is that of a small group of people most adversely affected by the SDO with increased adverse obstetric and social outcomes whose complex lives interface poorly with the existing provider-centered configuration of care. Their needs would be better met by decentralized, non-judgmental, flexible care models. There are systematic barriers for providers who want to do better, which relate to the unwieldy, opaque, siloed nature of the health and social service systems. And the same stigma that deters patients and clients from the system makes it difficult for willing care providers to create a community of practice that could improve client care. Now I'd like to highlight a few ideas that I found in my research that are either novel or compelling or both from each of the 4 themes that I have used to organize this work. You can see by this diagram that I feel that the themes are mutually informing and enforcing. So first, this theme of describing the problem uses the participants' own words to explain who struggles to access care and the barriers people face in accessing it. Here, I want to emphasize that there was consensus that inadequate prenatal care was a numerically small problem that warranted attention because of the potential impact genuine intervention could have on this small number of people directly, and by extension on the health and social service systems and society more broadly. Two notable aspects of care raised by participants that are particularly neglected, both in practice and in literature, were access to abortion and access to postpartum care. I will say just a few words about access to abortion. The issue was that people were not able to access it, and consequently carrying unwanted pregnancies to term. The ramifications of carrying to term an unwanted pregnancy likely to end in apprehension are beyond the scope of this study, but as human beings, I think we can all imagine some of them. The small amount of literature on this topic is quite compelling. It describes in their own words how women and non-binary people who have had their babies taken from them, whether the pregnancy was wanted or not, are carrying around an unbearable and unavowed grief that destroys their lives and can propel an intergenerational cycle of theft and loss. Improved access to prenatal care presents opportunities to decrease not only forced pregnancies, but also there is some evidence to suggest that it can be a mechanism for people who want to keep their babies to stay together as a family. These kinds of affirming interventions are what the participant, oh, I need to move the slide. This participant is getting at when they speak of the potential of these meaningful interventions to go beyond increasing a birth weight by 200 grams. Here, I want to relate back to the land acknowledgement. Our moral and legal obligations as settlers to Indigenous people on the question of child welfare are clear and set out in Canadian law. Indigenous people are overrepresented in the child welfare system and in populations of people who do not access prenatal care. The calls to action of the TRC and the final report of the National Inquiry on Missing and Murdered Indigenous Women and Girls call for an end to the targeting of Indigenous families for separation at the hands of child welfare. In both reports, health and social services are identified as sites of transformational practices to rectify past and ongoing transgressions. Addressing inadequate prenatal care offers a justice-oriented opportunity to intervening in the ongoing cycle of family separation, particularly as it relates to addressing the colonial legacies of residential schools and missing and murdered Indigenous women and girls. Experiencing the problem. This theme really elucidated what it was like to provide care in a system not designed to meet the needs of the patients and clients most at risk of adverse clinical and social outcomes. This theme was rife with words like chaos, worry, frustration, powerlessness, all related to the loss of control that comes from not being able to follow what is usually a very stepwise type of care. The loss of control was exacerbated by the ways which providers lacked expertise to attend to clinical and social complexities like homelessness, mental health concerns, and addictions. Providers often describe feeling powerless to provide better care within the system, even when they wanted to, blocked by a stigmatizing system and remuneration models and incompatible scopes of practice. That loss of ability to plan with the patient over the course of the pregnancy had consequences of varying degrees. In this quote, we can see how that inability to plan can have serious and long-reaching implications, coming back again to this question of apprehension. It's important to take a moment here to point out that many providers found a great deal of joy and meaning in this work, which served as an important counter-narrative to the many described drawbacks of providing care to people struggling to access it. It's really in this theme where we see the beginning of the call for leadership on the problem of inadequate prenatal care, both in terms of morale and clinical expertise. In this theme of experiencing the problem, we see the beginning of a sub-theme that ran through the entirety of the work and contributed to the feelings of frustration and powerlessness. The recognition that for so many, the barriers to care and improved health and social outcomes were outside the scope of clinical practice, and that there was little remedy for them within the health system. Under this theme of experiencing the problem, the inability to treat ESTO, as described as resulting from a lack of knowledge on the part of healthcare providers about the social service system and how to leverage it for their patients and clients. You might have to leverage it for your parents, I don't know. Next slide. There we go. Under this theme of addressing the problem, I collated the existing strategies and ideas for practice that could improve access to prenatal care. Here, the findings are quite consistent with the literature, and so I'm not going to belabor them because I will bring them up again in the implications section. But we must return here to the inability to treat the social determinants of health. While an improvement on the provider-centered model, the imagined solutions that I'll touch on in the implications section of interdisciplinary outreach-based care do not address the described roots of barriers to access, which are based in systems of power and privilege. Notably, despite the agreement that the roots of the patient's problems were the social determinants of health, few participants described or suggested ways to address these same roots. Healthcare provider strategies for increasing access as it relates to the ESTO were limited to referrals to social services, which they admittedly struggled to navigate and almost never described as mitigating or actually alleviating material deprivation. Only once during more than 25 hours of interviews did a participant suggest more money to clients as a way to increase access to care or improve health. I think this quotation from feminist, queer, and cultural theorist Gloria Anzaldúa is a nice transition between the descriptive themes in this work and what they say about how the problem is conceptualized. It was beyond the scope of this thesis to fully elaborate some of these connections, but referring back to the opening matrix diagram of the themes, I suggest that existing practice is constraining imagination and vice versa. All of it, practice and imagination, again to foreground the ideas central to critical theory, contained by systems of power and ideologies that grow up around them. Throughout the thesis, I tried to draw attention to the ways in which providers pointed to the ESTO origins of the barriers to access and impediment to improved outcome, but almost universally defaulted to individually mediated interventions. Here, I divide those perspectives into two primary categories: getting care as a responsibility of the patient, or providing care as a responsibility to the patient or the client. Forgive me, I present these in multiple different venues. Reflecting back to the WHO definition of ESTO, I want to submit to you that either orientation conceives of the ESTO as attributes of individuals, obfuscating the wider social and economic landscape that give rise to the poverty and the marginalization at issue. While not many participants espouse these kinds of views that are here in this quote, I would describe as the root of the stigma that permeates the health and social services system. They were universally described, unprompted, as the viewpoints of many of their colleagues. These are the kinds of widespread viewpoints that we don't get at in the meager literature on provider perceptions, because most of it is focused on the providers that do the work by choice and are hence unlikely to espouse these kinds of reductionist and victim-blaming attitudes. This quote here is more characteristic of the participants' conceptualizations of this problem. It's a little sneakier to unpack, but I argue nonetheless, it's still rooted in the kind of individualism that's so obvious in the previous conceptualization. This provider, like most in the study, connected issues of health and access and inequities to the ESTO, and then goes on to describe how the health and social service system should and could facilitate the needed change in individual patients to overcome their socially determined circumstances. Of course, clinical definition by practice happens at the level of the individual, and so individual level interventions to mitigate the impacts of ESTO make sense. What was notable to me, however, was how this provision of care aimed at addressing the ESTO was the ceiling and not the floor. Very few participants articulated the need, much less ideas about how to intervene into systems of power to address the ESTO at a societal level. For those few who did long for political change, most felt powerless to intervene for a variety of reasons. I'm just going to skip ahead so that I have a bit of time here. A few people did describe a justice orientation to inadequate prenatal care, which I feel ignites the possibility of a marriage, not a subordination of political action to clinical practice. I think this orientation holds exciting possibilities for thinking about and acting on the phenomena of inadequate prenatal care and improving health outcomes more broadly. So, implications for practice. My recommendations, coming from this research and a lot of clinical experience and speaking to clients and looking also at the quantitative data, is the formation and funding of an interdisciplinary midwifery-led outreach team organized around the principles of community-centered care. This targeted novel service delivery model should have multiple sites of low barrier on-the-spot intake to prenatal care provided by on-call midwives who could attend where and when the clients are by accepting referrals in real time. And additionally, midwives should provide care via an outreach service. Collaboration will be key to this program, with outreach midwives providing supportive and community-based outreach care to office-based OB and family medicine patients and vice versa. The program should work to address stigma in the health and social service sectors by providing harm reduction and anti-stigma education. The program needs to provide material supports to clients in the form of transportation vouchers, access to income through doing your taxes, the child tax benefit, special diet allowance for those who are familiar with the Ontario system. And the last two recommendations here flow from taking note of what was missing in the data, and a topic I'd be happy to elaborate on in the Q&A. We need to pay attention to racism in our outlooks and care models and overcome them. The program should involve people with lived experience at all levels of the design and implementation, including ensuring that this proposal is actually a good foundation to build from. Quickly on implications for research, since we're at the research symposium, I really love this quote. While describing very different circumstances, it gets right to the heart of the matter. From a technical health service delivery standpoint, I don't think we need more research, to be honest. We've known for decades that access to prenatal care and maternal and newborn outcomes are deeply tied to SES, and that what is required to facilitate access to care is low barrier, mobile, humanized healthcare that is organized around the needs of clients, not providers. The question for me really is, given that we know what is needed, why has it not been done? And as someone who's trying to build this type of programming, why is it so hard to do? These, to me, are questions ripe for investigation. I think that we need research that excavates, makes explicit, and mainstreams the ways in which we think healthcare research works and accounts for when and how it doesn't. Another interesting question for me is this complicated intellectual and theoretical turn that happens when a problem is widely defined as being rooted in the social determinants of health, but the remedy is conceptualized as needing to happen in the client. To my mind, there would be great value in excavating these assumptions buried in what Menatier and colleagues have described the individualization of social class, wherein social disparities are viewed as attributes of individuals and thus so too the site of their remedy. What I see as needed is the development of an interdisciplinary frame of reference that allows us to reconceptualize and mainstream intervening into problems of health and health inequalities, not as technical problems, but as political ones. Prenatal care is important. On a case-by-case basis, it offers access to life-saving, preventative, and therapeutic interventions. If it's done well, it can transform a person's relationship with hitherto oppressive and dehumanizing health and social service systems. It can be a mechanism for keeping families too often separated together, but we need to be explicit about what it can do and grapple with the importance of what it can't. Then we must decide how to implicate ourselves as health workers in that reality. If we take as fact that injustice is at the root of what keeps people from accessing prenatal care and overdetermines adverse outcomes, we need a radical honesty about what the answers to those health problems are. Thank you.
Thank you so much, Lisa. Again, you can hear the virtual applause, but and so much to unpack here as well. And I know you're so passionate about this topic, and this is again a slice of the work that you have been doing. And I'm grateful to be in a community where you continue to push these boundaries and ask these questions. But I think so much of this is applicable to many other settings. So it's been fantastic to hear your findings. We do have time for probably a couple of questions. In general, so far, lots of comments in the chat about just how much people appreciate this work, and how important it is to see work like this in Canada in particular, and support for the idea of funding, all the things that we need to do to make the system better. I'll just pull up the Q&A and see if there's any other specific questions. Just lots of thanks. Thanks for the beautiful but very touching work of advocacy. Your area of interest really resonates. So I think lots of people really feeling that this is such an important topic. Let me go through the chat and see if there's anything else. Someone did raise a question about the kind of interprofessional nature of, strategies to address this, and how, let me see if I can find it. It was Lisa said, I also feel that working together alongside other professionals would help increasing access to prenatal care. For example, some people may be deemed high risk for a midwife, but if we were able to work together with an OB and facilitate consults for substance abuse, then we would be able to improve health outcomes. There seems to be such a huge distance between us and them. And so they were reflecting as well on how that may be the nature of work here in Canada, but that there may be models of that kind of better integration of interprofessional work in the UK, Australia, New Zealand. I don't know if that's something you want to comment on as you've thought about, the way forward for some of this work.
Definitely. I mean, there's quite a bit in the work about the difficulties that are created by both the siloed nature of health and social services and the different barriers that are presented by the clinical scope of practice and the remuneration models here in Ontario. And so that's definitely something to overcome. And I think one of the things that but it's really a necessary thing to tackle, this question of interdisciplinary work. And one of the ways that I'm quite proud of this work is how it's lived in the community, and that it's a real for me, speaks to the importance of midwifery-led research. We started this program 10 years ago, just sort of like there's a gap. Midwives know how to go out in the community and do work that's on call and mobile. And why don't we just add that layer to an existing physician-led practice? And in doing the midwifery and doing the work, and then bringing together the research program around the work, it really, I've been really pleased at the way in which the community has been willing to accept leadership from a midwife, which I think, some of us struggle with. Liz spoke to it in her presentation as well. But if there is a gap, and there's my experience has been anyway, that a midwife stepping forward and saying, I'm going to lead the charge, come with me. What do you think what are your barriers to providing care? And there were a lot of really honest sort of revelations about the barriers to collaboration in this work, but also a real commitment to trying to work to overcome it. So thanks to the organizers and to the builders of the research, the Midwifery Research Center, because I think midwifery-led research is an important contributor to increasing those interprofessional collaborations where they're needed, and to building midwifery leadership.
Yeah, I was going to say, I think there's some really important lessons about midwifery leadership in that and what you just said. So yeah, we're very thankful that you've been involved in that, and so great to see this work come together over the past decade. Hard to imagine that that's how long it's been going on. I will wrap things up there. I am mindful of the time. There'll be another quick little poll for you to fill out, and then a reminder as well that you will get a follow-up questionnaire about your attendance at the symposium today. And if you need a certificate of attendance, that's the way to obtain one, is to complete that survey. We will be right back here on Zoom, same link as you used today and every day this week. So please join us again. I'm just going to highlight a few things that are coming up in the week. So tomorrow, starting at noon, we are honored to be a co-host of a panel discussion with the National Aboriginal Council of Midwives. The panel discussion is entitled "Finding Out What Matters to Us, the Importance of Indigenous-Led Midwifery Research for Improving Health and Well-Being." So please come and join us for that. On Wednesday, we also have a panel discussion, and this one is co-hosted with the Global Network for World Health Organization Collaborating Centers for Nursing and Midwifery, the Midwifery Network webinar. And the topic will be global perspectives on the role of midwives in safe abortion care. And we've got some of the panelists that are attending that day listed on the slide you can see right now. So lots of great speakers that will be here on both Tuesday and Wednesday as part of those panel discussions. And then Thursday, we have another keynote looking at safety of forceps and vacuum in Canada and comparing that to international perspectives. We are going to take a little deep dive into the birth space and how intentional design in the birth environment can impact people's experiences. And then we will also be looking at antibiotic resistance in the gut microbiome of preterm infants. So we are covering a lot of ground this week. And then Friday, finally, we have our last keynote where we're going to be talking about the hot topic of induction of labor. And then we're also going to sink our teeth into a really interesting kind of workshop and discussion with a group out of London, Ontario, who've been looking at implementing oxytocin training for midwives. So lots to participate in, and hopefully some of that will spark your interest and that you'll come and join us on a future day. So I look forward to seeing you then, and enjoy the rest of your day.